thumbnail images. It's a client who attended yesterday actually, but she originally attended at the latter end of last week. She reported severe otalgia of the left ear. So otalgia is an earache. She's had it for a couple of months. She's been treated with antibiotics by her GP. She's got immense swelling in the ear canal and inflammation. The doctor also advised that the patient's got earwax and recommended to use some olive oil earwax softening drops. So she's been doing this for the last couple of months, and her symptoms have just got worse and worse. And when she attended last week, there was a bit of lateral earwax near the entrance, which was really soft, which I removed. But then we came face to face with this. So a lot of dead skin, well, there's a plug of dead skin, almost. You could say it's also keratosis obturans, and spent about 20-30 minutes at the last appointment trying to remove it, but it was rock solid, it was stuck, and there was just no way of having that plug of dead keratin removed. And her ear canal was also very inflamed, very swollen. I did manage to get a bit of it out, which released some of her otalgia earache, because the wax was compressed. She was saying that when she was chewing, she couldn't even chew basically from the left side because her jaw and ear hurted so much. So it's almost like her jaw and her ear canal it's almost like a nutcracker. You've got a nut and then you've got the cracker, and the nutcracker is almost like her jaw over the plug of wax. So it's that hard, and it was so painful for her that she even said she wasn't really talking much because it was so painful. So you can imagine how much of a struggle it was last time. We did put some sodium bicarbonate drops in for about 20 minutes, I think, last time, just to soften it, but it just wasn't going to remove. So I advise the patient to use sodium bicarbonate drops, which is far, far more effective when you've got dead keratin, dead skin, compared to olive oil drops. She used it twice a day, soaked her ear for 20 minutes, I believe I told her to do, and followed by 10 minutes of draining. Twice a day, last Friday, Saturday, Sunday, and she returned yesterday. So the keratin is a lot softer, but it's still very impacted, and it's engulfed within the ear canal. So this ear canal, as I mentioned at the beginning, is further into the ear canal. It's very inflamed, very swollen. It's trapped the wax, it's not wax, sorry, keratin. And keratin it can be a very sticky glue-like substance, and it's adhered to the canal wall, so the ear canal doesn't want to let it go. And on top of that, with it being obviously the ear canal inflamed, it's just a very difficult procedure. And you'll see I used a range of instruments. We're just trying to lift this keratin plug off the base of the ear canal. Really tugging away here. The patient was fantastic. So obviously she was still in a bit of pain before she attended today, but not as much as last time. And I just had to get this out by all means today. You can see I'm trying to bring this keratin through. Just where I'm pulling it on the right hand side, the ear canal kind of widens, so it's trapped, it's stuck. You can see that keratin now trying to being lifted off the canal wall, and it springs back. That's the thing with keratin, it's almost like a rubber band. You pull it and you let go, and it springs back in place. So it's one of the worst things to remove. Is this keratosis obturans? It can be. Keratosis obturans is when your ear loses the ability the skin in the ear canal loses its ability to migrate, and eventually you develop a skin plug. With this patient, she had an infection, so there was always swelling there already. She's also been using cotton buds, so this skin may have come out on its own accord, we just don't know. But obviously with the ear canal being swollen and pushing into the ear, it really impacted it. So it is likely that she has got keratosis obturans, but we're going to get her back in 6 months and to monitor it. And obviously I did manage, as you can probably tell by the thumbnail, to remove this plug. I was just told her to use sodium bicarbonate earwax drops regularly. There was also a surprise in the right ear. So this is the patient's left ear, so do stay tuned in, because at the end of this procedure we also show you her right ear, and there was a bit of a surprise there, something completely unbeknown to the patient. Even with the left ear, the eardrum, and again you'll see it a bit later on in the procedure, She also, the eardrum was very dull and inflamed, and she also had glue ear. So glue ear, another name is acute otitis media with effusion. So it's a buildup of fluid behind the eardrum due to a blocked eustachian tube. So the eustachian tube is the pressure equalizer. It's a narrow tube behind the eardrum that connects to the back of the nasopharynx. It's not only the pressure equalizer in the ear, because we want the air pressure behind the eardrum to be in equilibrium with the air pressure in the atmosphere. And when the air pressure either side of the eardrum is equal, the eardrum is at its most compliant, most mobile, and it's the function of the eustachian tube to do that. The eustachian tube is normally closed, and it opens through brief moments of chewing and yawning, and it's during those brief moments the air equalizes itself. If the eustachian tube was permanently opened, it's what we call patulous eustachian tube, and we don't want that because you can get other symptoms like autophony, so you can hear yourself in your head. You get a very muffled sensation of your voice. I'll come back to that in a moment. So obviously we're trying to use suction, kind of loosen some of the keratin, but it was springing back. So quite often in some of these videos, and I know for a fact I'm gonna, well, I don't really read the comments much, but why didn't you use this instrument? Why didn't you use that? Kind of obviously, you know who you are. Well, here's a classic example. I'm using forceps, it's just shredding it. I've even gone with these are some Henkel forceps. Just about fits in the ear. Doesn't really do much. So there's a time and place when you use different instruments. So just going back in with the solar suction probe, you can see just to the right, this plug of skin, it kind of goes into this opening on the ear canal, on both sides actually, but more so on the right. So the only way really, I mean, there was a point in my head where I was thinking, well, this patient may just need a GA, because obviously it was a bit uncomfortable for her. There's nothing I could do really, but she was fine. It wasn't uncomfortable to the point where she wouldn't want me to continue. But imagine this was your ear, and it's already painful before you come in. You've had several ear infections. You've got this plug of keratin. It's painful to the point that you can't even talk or chew. That's what we're dealing with here. So she was fine with me to continue. We just had to get this out. But sometimes under these circumstances, if the patient finds it very, very uncomfortable, I think we've had one client in the past who saw an ENT colleague, came to see me, and it was the same outcome. It was just too uncomfortable, and eventually I just have to refer back to the ENT, and they agreed that they had to do a general anaesthetic procedure to remove plug of keratin. You can see it's a bit damp in the distance, and that's what happens with dead keratin. It dies, it gets infected, it gets moist, you get all this humidity. And patience is a virtue. We just have to persevere. There's no other way of removing this. So going to be going with an ear hook, and again, people say, oh, why don't you use an ear hook? Well, have a look, guys. That's why, because it's not really effective. She did find this part because she's slightly uncomfortable. I'm trying to get in behind. I'm trying to get into this widening of the ear canal where the swelling is. So you've got the swelling, and then behind that, the ear canal widens up. You'll see at the end, this keratin has been in the ear for such a long time, and it's caused widening, erosion of the ear canal wall. So her annulus region, which is the region near the eardrum at the base, the floor of the eardrum, is really widened. So there's also potential, she may have a bit of a canal cholesteatoma. So we have referred to ENT, not only because of this ear, because of the glue ear that she's also got in this ear, but also because of the condition of her right eardrum, which we'll show you later. So the patient attended with her daughter, so I actually asked their daughter to watch what I was doing. So she's, because sometimes patients also themselves are just thinking, just got a bit of wax, why is it so difficult? They've got a vacuum, it should be nice and easy. So I wanted the daughter to see as well what we're doing and how difficult it was, and she was actually standing behind me, and she was just gobsmacked. She didn't realise that her mum's ear was this in such a condition. You see, I'm just trying to pull this plug of keratin underneath this inflammation of skin, of her ear canal, sorry. And you can see the layers of keratin there, and the thickest one is on the outside of the perimeter, the white the white stuff. But again, we're just trying to pull this down. The patient was finding this a bit uncomfortable, but she was happy for me to continue. So I'm just bringing it underneath, trying to bring it through, but it did spring back a few times. And that's the thing with keratin, it's very spongy, rubbery, sticky. It's quite a frustrating thing to remove because you feel, at this point I think, yes, eureka, this is going to come out, and it just eventually springs back into place. Just block the tube. And I'm applying so much pressure here, so you can't tell by just watching the video itself, but the daughter could see when I got a suction grip, I was really tugging at this, really bringing it forwards, but it was just pulling back. You can see there, as soon as I lost a suction grip, this plug of keratin just bounced back, almost like a trap door. Didn't use any more drops because the patients had been using drops, as I said, for several days. She really dosed her ears, so if that wasn't going to do it, then me putting some more drops during this procedure, it wasn't really going to have any additional effect. So I did promise the daughter and the mum that I would get this out today, because she was really, it was getting to her, she was getting quite depressed. Although her symptoms had improved since the last appointment, she could still feel, obviously, a fullness blockage, reduced hearing, a bit of pain, although the pain was nowhere to the extent it was last week. So I'll just go back to the patulous eustachian tube. So that's when the eustachian tube is permanently open. That's not a good thing, because one of the functions of the eustachian tube as well is when it's permanently closed, it stops your internal sounds, so respiratory sounds, cardiovascular sounds, your own voice, when you eat or you chew, to travel up the eustachian tube and vibrate off the eardrum, because that will amplify your own sounds in your head. So people with patulous eustachian tube, and that's when the eustachian tube is permanently open, when they breathe in and out, when you look and you're examining the ear, you can actually see the eardrum going backwards and forwards in synchrony with the inspiration and expiration. So, and the patients can hear themselves breathing. Also, when they're talking, their own voice doesn't only travel out their mouth into the air and through the ear canals, but it also travels up the back of the nose, up the eustachian tube, and they can hear themselves twice, so they get a mismatch. People who've lost a lot of weight or do a lot of exercise, doesn't mean everyone who does a lot of exercise is going to get patulous eustachian tube, but it's one of the triggers. Or pregnant women, actually. So I think the reason for that is during the last few months of pregnancy, your body's preparing, obviously, itself to give birth, so the muscles relax, so hormones are released into the body to help, obviously, the womb expand, so it helps deliver the baby, and I suspect that also relaxes some of the muscles in the eustachian tube, so the eustachian tube loses its kind of stiffness, so it just flaps open. It's not common you see patulous eustachian tube. I've had a few instances. Some of the treatments are, some of the ENT surgeons inject some fatty tissue into the eustachian tube to narrow it. I've heard of some ENT put a bit of blue tack onto the eardrum to stiffen the eardrum, so the sounds travelling up behind the eardrum to the eustachian tube doesn't cause the eardrum to vibrate, but obviously that could also have an impact on external sounds going into the ear. So the eardrum hasn't got, so the eardrum works in two ways, so it's a bit of a science lecture. Some people enjoy it. I apologise if you don't. The eardrum has two components. It's either stiffness dominated or mass dominated. So if the eardrum has become stiff, and typically it becomes stiff if the bones or the ossicles attached to the eardrum become stiff themselves, so otosclerosis for example, it attenuates, so it reflects low frequency sounds. If your eardrum and middle ear is more mass dominated, so there's extra weight, it attenuates high frequency sounds. So blue tack will add additional weight to the eardrum. It could also increase stiffness, so it can attenuate not only the high frequency sounds but also the low frequency sounds. Anyway, going back to the procedure, you can see I'm still tugging away here, bringing this forwards, and we are getting somewhere now. Sometimes you just have to wear it down. It's a battle between me and the plug of wax, and it's a battle of stamina and perseverance. This plug of keratin is doing everything in its power not to come out. You can see how stuck it is. And you just have to persevere. There's no other way, it's no shortcut. So the bit we're trying to pull off now, this is actually adhered to the eardrum, so it's a lot more medial. So far we've used an ear hook. The ear hook just sliced through it, it wasn't removing it. The forceps was just shredding it. The Jobson horn really, it's not really a suitable instrument for this because there's nothing to, it's impossible to get in and behind the wax because of the shape of the Jobson horn, the surface area. And quite often in these cases you see some of the comments, it's quite critical, you keep using suction, well, by all means, if you want to do the procedure, you're more than happy to do so, but you'll see the value of suction here, it really does, in the end, do the job. So we're bringing this through still, really pulling at it, and you can see I'm tugging at it so much that when we lose the suction grip, that keratin just springs back, it just goes back into the ear. See, this is where the swelling is, and then behind the swelling, the ear canal expands. So we're just bringing it through the swelling, and I've just got a bit of headway now. So at this point, I was thinking, well, maybe we would be able to remove this today. There we are. So I've had to somehow manipulate, rotate this keratin into a different orientation to bring it through, but it's still stuck. You can see it's still pulling away at it and it doesn't want to come out. You can see all that fresh layer of keratin, the sticky stuff, the really white stuff. As you can see, it's almost like a rainbow effect, but obviously all shades of yellow, and from the core to the outer part, it gets from a dark brown to a white appearance, and that's the different layers of keratin. So the whiter stuff is the fresher stuff, the bit in the middle, the core, is the older keratin, and it kind of coils. It's almost like a cigar almost. You wrap it around, you get different kind of layers. So I'm just going a bit deeper, bringing this even bigger plug of keratin through, just getting some leverage. And in a moment I'm going to finish the job off using some forceps. So there's a time and place for all the instruments. You saw earlier the forceps wasn't doing anything, it was just shredding the keratin. I'm still really yanking away here, you can see. So, but we are getting there. Gone in with some crocodile forceps. Again, it just shredded some of it. So I think I'm going to be using the Henkel forceps. It has a better surface area. There we are. Huge plug. I think it measured about 2.6 centimeters. So it's not a very healthy looking ear, is it? So quite often with keratosis obturans or a plug of dead keratin, it's very damp in the ear because of the humidity, all the dead skin has died, it's shedded and it became wet. So just want to mop up in there. It's going to probably be a bit boring for some of you, but I just wanted to show the whole procedure. The patient's ear still, like, she obviously felt over the moon, a lot of relief after removing that plug. But her ear's still, obviously, it's quite inflamed and it's still sensitive, so we're still going to be very careful. And it's not possible we didn't remove every single last piece of keratin. That's just virtually impossible. But we're just trying to mop up as much as possible. At the moment, the eardrum's still not very visible. The landmarks, we know where the eardrum is. I was just on it a couple of seconds ago, but I can't see the handle of malleus. So we're just getting some dead keratin, just being very careful. And it's going to let you watch this bit because it's probably going to be a bit boring me talking at the same time. You'll see how widened and eroded ear canal is this deep in the ear. Probably got some granulation tissue at the bottom. You can see the red dot there. It's just what we call, it could be myringitis. Myringitis is like an infection of the eardrum, but I think that was granulation tissue. It's just healing connective tissue, and you can get a bit, the texture can become a bit rough sometimes and it can get red. So you can probably see the swelling a bit more. You can see the swelling there just on the right hand side, a bit of flesh, and then beyond that swelling the ear canal widens. Quite often you do get some blistering, some bruising, bleeding when we remove keratin off the canals. You can see a bit there on the anterior canal wall. It's just like a blister. If you've got a bit of skin on your finger and you peel it, you do get a bit of blistering and bleeding. So just trying to mop. It's, as I say, it's just not possible to get every little speck out. The ear is still very sensitive, so just trying to get as much out as safely as we can. In a moment I will be going to the eardrum. I'm just going to fast forward some of these clips because I appreciate some of you might find it a bit boring, and so you're waiting to tune in for her other ear, her right ear. So just bear with me. I'm just going to pause the commentary and just fast forward these clips a bit. So I'm just fast forwarding some of these clips. I've just put the speed on 1.5. Got some dead keratin at the roof, the ear canal, just using a fine end gorge there, so it can get blocked a bit easier. So I'll be going in and out of the ear quite often with the fine end gorge. She found that slightly uncomfortable, so I just came back out and just going for different regions. So just on the posterior canal wall, big piece of keratin there. And some of the skin, although you feel that you can remove, it's not ready to be removed, so you can't feel. If you've got your layer of skin on your finger and it's a fresh layer and you want to peel it, well, that's not going to happen. So we're just trying to remove the bits that are wanting to come out. So just at this is the back of the eardrum now, so the posterior quadrant. See the handle of malleus there, and there's a bit of where we're going to now. That's the attic, the superior anterior quadrant. It's a bit of dampness, wetness on the eardrum. So just going into what we call the pars flaccida, which is a very thin part of the eardrum, just to take that off the eardrum. So you can see the handle of malleus there, but the eardrum itself is a bit dull, it's a bit red, it's a bit inflamed. And we perform tympanometry. So tympanometry is a pressure test. We're actually measuring the admittance, so how much sound the eardrum, the middle ear, is absorbing, by actually measuring the admittance. So essentially we play a sound into the ear and we change the pressure in the ear canal, and we measure how much sound is being reflected back out of the ear. So the more sound that's being reflected back out of the ear from the eardrum, the less sound is obviously entering through the eardrum. So we can then ascertain how mobile the eardrum is. And when I performed tympanometry, we got what we call a type B tympanogram. So there's no peak. So at the moment the eardrum is mobile, we get a big peak on the screen, and that's depending upon the air pressure as well behind the eardrum. So as I said right at the beginning, the eardrum is at its most compliant when the air pressure behind the ear is equal to the atmosphere. So we do we do a sweep of air pressure in the ear from negative to positive, and we measure the moment where the eardrum is most mobile, and we can correlate that to the air pressure, so we know whether there is a negative air pressure behind the eardrum or positive. And the type B tymp is when there's no mobility of the eardrum, there's no peak, and that's what this patient had on this side. So again, she found that bit a bit uncomfortable just at the root, so just gonna try again. Otherwise, remember, her ear's still swollen, it's still a bit inflamed. She did want me to just get as much out as we can comfortably, and that's what we did. And we can see the eardrum now. So just over to the right side. So the right side of the wax, it's more wax here, a bit of dead skin as well, but it's definitely more wax, a bit sticky in consistency. So it's just blocking the tube. So I think I went in with a Jobson horn in a moment. So I'm just going posteriorly, trying to get in behind the wax, scooping forwards, but again, it's still quite soft and mushy. So just got a little bit out. So I decided to put some olive oil drops in. I've gone back in with the suction probe. Well, I think I'm putting the drops in a moment. Once I got this plug of skin out, I'll tell you what we saw. She had unbeknown to her, a very large posterior inferior quadrant perforation, and it's a brilliant view. You can see right through the eardrum, and she also had tympanosclerosis, so the eardrum itself was scarred, it was opaque, it was white, calcification. So she's obviously also had quite possibly glue ear in this side, so that fluid buildup that she's got in the left ear, she must have had this in the right ear many years ago, and eventually that fluid has to go somewhere. It's like a blocked drain pipe, eventually it's going to burst through and it punctures through the eardrum, so that's probably what's caused her perforation. So I just use some olive oil drops, just loosen this, come out in a nice big chunk, and you'll have a lovely view of the tympanic membrane. So you can see south west, there's a big hole there. See right through the eardrum, bit of tympanosclerotic plaque developing down the eardrum. The right side of the eardrum is all opaque, so that's all calcification. So that's probably her pulmonary, which is the spiral of the cochlea that we can see. There's that plug of keratin, plug of skin, almost half or more than half a gram, and it measured 2.4 centimeters, and in inches it was just below 1 inch, 0.946 inches. I hope you enjoyed that video, guys. I've got some other good ones coming up, some big extractions, big large chunks, so stay tuned. If you're watching on YouTube, please do subscribe, select the bell icon, you'll get notified as and when I upload new videos. If you're watching on Facebook, similarly, like,